So let's move to the next speaker, Dr. Bevin Borul, which is going to talk about new data on the various alopecia.
Thank you, Dominique, and thank you to IMCAS for inviting me to talk about these scarring alopecias, namely frontal fibrosing alopecia, lichen planopilaris, and decalva. So I'm going to focus on some of the latest and, in my opinion, most relevant research, specifically on the pathobiology and treatment of these scarring alopecias. Now, I'm sure everybody knows that scarring alopecias represent a frustrating group of conditions because, well, first of all, the cause of virtually all scarring alopecias is unknown. Treatment is often disappointing, and irreversible hair loss has a devastating effect on the lives of sufferers. So, I'll start with lichen planopilaris. So it is widely believed that lichen planopilaris is autoimmune, and that stems from the observation of the perifollicular lymphocytic infiltrate that we see in biopsy specimens of lichen planopilaris. And in LPP, this infiltrate centers around the infundibula and the bulge, which is home to the hair follicle stem cells. And in fact, it has been shown that levels of keratin 15, which is a marker for hair follicle stem cells, are regulated in the bulge, suggesting hair follicle stem cell destruction. This was an important study done just about 13 years ago, showing a link between LPP and PDAR, which stands for peroxisome proliferator activated receptor gamma. PDAR gamma is a transcription factor which is homeostasis, and the relevance to LPP may be that so PDAR gamma downregulates the expression of pro-inflammatory cytokines and chemokines, and increases the expression of apoptosis-related genes. So this study by Karnik and colleagues showed that PPAR gamma was downregulated in both affected and unaffected LPP specimens. And the authors also showed that knockout of PPAR gamma in hair follicle stem cells in mice caused a scarring alopecia which resembled LPP. So this work by Matt Harries and colleagues looked at the bulge immune privilege in lichen planopilaris. So we know that the hair follicle bulge enjoys this state of immune privilege, which is lost in alopecia areata. And the authors here shows that there is a similar immune privilege around the hair follicle bulge. And that is, as with the bulb, characterized by downregulation of MHC classes 1 and 2, as well as the expression of what the authors call immune privilege guardians, which are local immunosuppressants such as alpha, MSH, TGF, beta 2, and IDO. So in lichen planopilaris, the authors observed that there was a collapse of bulge immune privilege, which they showed with the upregulation of MHC classes 1 and 2, and a downregulation of the no danger signal CD200, as well as the immune privilege guardian TGF beta 2. The infiltrate around the bulge was rich in cytotoxic T cells, and they confirmed hair follicle stem cell destruction with the downregulation of stem cell markers keratin 15 and CD200. So as in alopecia areata, in interferon gamma plays a key role in collapse of the immune privilege in lichen planopilaris. There is an older study that showed that deletion of hair follicle stem cells causes permanent hair loss without the other features of lichen planopilaris, such as atrophy, inflammation, and fibrosis. So the authors rightly observed that loss of hair follicle stem cells alone is probably not enough to explain all the features of LPP. So the same group went on to look at the possibility of epithelial mesenchymal transition in LPP that could explain the other features, such as scarring. Epithelial mesenchymal transition, or EMT, refers to a phenomenon whereby epithelial cells lose their polarity and adopt a fibroblast-like morphology. So in this study, the authors showed that in LPP and frontal fibrosing alopecia samples, there was a downregulation of epithelial markers such as E-cadherin and upregulation of mesenchymal markers such as vimentin and fibronectin, as well as an upregulation of markers of EMT such as snail and twist. They showed that some of the cells in the bulge co-express vimentin and A15. So vimentin is a mesenchymal marker, whereas keratin 15 is a hair follicle stem cell marker. So this suggested that those hair follicle stem cells underwent that transition, which turned them into mesenchymal-like cells. And finally, they confirmed their observations by inducing epithelial mesenchymal transition in normal hair follicles by using a cocktail which contained, among others, interferon gamma. So this is a diagram from their paper. So in these histological images, you can see in the LPP hair follicle that the epithelial cells, that the cells of the follicular epithelium, have adopted a fibroblast-like morphology and have lost their polarity, so they're not close to each other. As I mentioned on the previous slide, there's a downregulation of the epithelial marker E-cadherin, and an upregulation of the mesenchymal markers and the markers of epithelial mesenchymal transition. So moving on to frontal fibrosing alopecia, which is just as obscure as lichen planopilaris. Dermatologists are familiar with the fact that there is an explosion of cases of frontal fibrosing alopecia, but while there are theories as to why this may be happening, the actual cause of this is as yet unknown. This was a genome-wide association study from the UK of women with frontal fibrosing alopecia, which identified a variant in the CYP1B1 gene, which encodes cytochrome P451B1, which is involved in the metabolism of estrogen. So, based on this observation, the authors postulated a potential role for the oral contraceptive in the etiology of FFA. Oral contraceptives were in fact introduced in the 1960s. I'm just going to move on to two recent studies by the same group, which looked at FFA samples. This first study, as with LPP, the FFA specimens were rich in cytotoxic T cells as well as dendritic cells, and the authors showed upregulation of T cell and natural killer cell markers such as the interleukins IL-2, IL-15, and granzyme B. They also showed an increase in the markers of T helper 1 cells in FFA versus alopecia areata samples and controls. We've just heard about JAK inhibitors for alopecia areata, but the authors, based on the observation of the increased expression of STAT1 and JAK3 in the FFA samples, suggested that JAK inhibitors may represent a good therapeutic option for frontal fibrosing alopecia. So as with LPP, there was an increase in mesenchymal and EMT markers in FFA samples. So in virtually all scarring alopecias, there is the observation of loss of hair follicle stem cells, and frontal fibrosing alopecia is no different. So in this study, the authors showed downregulation of keratin 15 and CD200 in FFA samples, which was not observed in alopecia areata samples, confirming that in FFA there is destruction of hair follicle stem cells. Interestingly, they also showed a correlation, a direct correlation between JAK-STAT signaling and the extent of fibrosis in FFA samples. So this was a study that this was work that was done by Professor Messenger's group in the UK, looking at potential causes of frontal fibrosing alopecia, and it was a questionnaire study which identified sunscreens and leave-on facial products as having a potential role in the pathogenesis of frontal fibrosing alopecia. They also observed an increased frequency of positive patch tests, especially to fragrances in the FFA group. There are two schools of thought as far as this is concerned, with some dermatologists very much in favor of a role for sunscreens, whereas others are not convinced. So there have been systematic reviews that have suggested that as of yet there is insufficient evidence to support a role for sunscreens in FFA. However, one study from last year showed that in FFA samples there was an increase in titanium-containing nanoparticles, nearly 9 times as much as in control hair follicles. So based on the work of Dr. Karnik and colleagues who showed downregulation of PPAR gamma in lichen planopilaris, the use of pioglitazone, which is a PPAR gamma agonist, has increased to treat LPP. And there are a few studies which have shown some success in refractory cases of LPP. So there was this case report by Dr. Karnik and Mermarani showed a reduction in symptoms and signs of inflammation, which they confirmed on histology. And interestingly, a case series of 24 patients even showed a regrowth in some cases. Only a minority of patients relapsed after treatment discontinuation. One of the problems with pioglitazone is the high frequency of side effects, including edema, weight gain, and resistant hypertension. This is a study we performed with Sergio's group, looking at the use of low-dose oral minoxidil in lichen planopilaris, and most of our patients either stabilized or showed an improvement in their hair density, which we postulated to be as a result of an increase in hair density in the unaffected areas. As with androgenetic alopecia, which we've heard from Sergio, minoxidil, low-dose oral minoxidil was well tolerated in the vast majority of our patients. JAK inhibitors have become popular for treating alopecia areata. About lichen planopilaris, so there are 2 case series, to my knowledge, describing the use of JAK inhibitors, describing the use of tofacitinib for LPP, refractory cases of LPP. The first study showed a reduction in the lichen planopilaris activity index between 30 and 94%, whereas the second study showed an improvement in the vast majority of their patients. As we see with alopecia areata, tofacitinib was well tolerated. Now, one limitation of these 2 studies is that they both used concurrent therapies, which makes conclusions a bit difficult. Our group looked at the use of baricitinib for lichen planopilaris. We we had more disappointing results than the tofacitinib studies. So although initially most of our patients improved with a reduction in their LPPAIs, the effect was sustained in only about half of our patients. We also used concurrent treatments, which makes firm conclusions about the use of baricitinib for LPP difficult. Now, the reasons for this, in my opinion, might be twofold. One, all 12 patients had very resistant LPP, and two, we saw from the previous study that increased expression of JAK3 has been seen in FFA. Now, baricitinib is a JAK1/2 inhibitor, whereas tofacitinib is a JAK1/3 inhibitor. So this was another study from Sergio's group looking at the use of dutasteride for frontal fibrosing alopecia, a study published last year in the Blue Journal. And while we, a lot of us use dutasteride for frontal fibrosing alopecia, this important work confirmed that the improvement seen with dutasteride is dose dependent. So the authors showed that after 2 years, over half of patients treated with dutasteride had achieved a stabilization of their condition, and this was superior to finasteride. Now, it has to be said that the figure of 57.1% represents patients on all doses of finasteride, but when the authors substratified the different doses of dutasteride, they observed that 100% of patients who received 5 to 7 tablets per week achieved stabilization of their hairline. And as you'd expect, side effects were minimal. So I'll move on to folliculitis decalvans, which is another frustrating scarring alopecia. This landmark study published in the Journal of the EADV in 2013 showed the presence of bacterial biofilms in the infundibulum of hair follicles of folliculitis decalvans. However, most of the controls also had bacterial biofilms. Nevertheless, the authors suggested that these bacterial biofilms could still have a role with a pathogenic shift happening in folliculitis decalvans. So this is yet another study by Sergio's group, which looked at whether the microbiologic signature could dictate the phenotype of patients with folliculitis decalvans. So whether patients would present with classical folliculitis decalvans or folliculitis decalvans like in planopilaris phenotypic spectrum. And in fact, the study showed that in patients with typical folliculitis decalvans, over 20% of the bacterial composition consisted of Staphylococcus aureus, whereas in patients with folliculitis decalvans, like in planopilaris phenotypic spectrum, less than 20% of the bacterial composition consisted of Staph aureus. So I'll just move on to PDT for folliculitis decalvans. This was an interesting study which argued that prior studies of PDT for folliculitis decalvans had been disappointing because the light did not irradiate the entire patch or patches of folliculitis decalvans. So they used a flexible light source, as you can see in this diagram. And most of their patients had a good result with a reduction in the typical symptoms of folliculitis decalvans, which are pain, burning, and pustulation, and a stabilization of their alopecic patches. Unfortunately, most of these patients were on concomitant treatments such as Humira and isotretinoin, which again makes conclusions difficult. And this was another study of 13 patients with folliculitis decalvans treated with PDT. In this study, all patients had a positive outcome, either with complete recovery or improvement. I put a question mark about diagnosis because the paper has a photograph of a patient who appears to have acne keloidalis nuclei, which to me again highlights one of the challenges of scarring alopecias, which is establishing a proper diagnosis. And this is one more study from Sergio's group, which looked at topical dapsone for folliculitis decalvans. So I thought this was an interesting study because topical dapsone is a safe treatment option, and the authors demonstrated a reduction in frequency of flare-ups in patients who were treated with topical dapsone. So the last study for folliculitis decalvans was a case series of 23 patients treated with adalimumab at doses higher than the doses we use for psoriasis, based on the hypothesis that tumor necrosis factor alpha may play a role in this condition. And in fact, all the patients had a positive outcome with a reduction in the symptoms and signs of folliculitis decalvans. The Humira was well tolerated. I'm just going to end, so I briefly mentioned folliculitis decalvans lichen planopilaris phenotypic spectrum in an earlier slide, but I'm just going to end with this. So this was published 2 years ago in Clinical and Experimental Dermatology, and described this potentially new scarring alopecia, either a new scarring alopecia or an alopecia or a scarring alopecia, which is a variant combining features of two conditions that we're familiar with, folliculitis decalvans and lichen planopilaris. So the authors included 13 patients. So 6 of their patients had sequential folliculitis decalvans and lichen planopilaris. So they initially presented with features of folliculitis decalvans, which over time changed to predominant features of lichen planopilaris, whereas the rest of their patients had simultaneous features of folliculitis decalvans and LPP, presenting in different scalp locations. They suggested that the phenotype may have been altered by therapy, and they commented in their conclusion that lichen planopilaris may in fact represent a final common pathway all primary cicatricial alopecias. I'm not sure I agree with that comment, given that personally with certain scarring alopecias like acne keloidalis nuclei, and perhaps dissecting cellulitis, I never actually see them change phenotypically to an LPP like alopecia. But it'd be interesting to hear the thoughts of the rest of the faculty. So this was one of their patients. You can see on the left with this kind of beefy perifollicular inflammation, pustules, crusts, whereas on the right, there's more atrophy. You can probably appreciate the perifollicular scale, the perifollicular erythema at the periphery. So on the right, it looks more like LP. I'm going to end here. Thank you.
Thank you. Thank you very much, Dr. Boru. That was very comprehensive indeed for challenging condition. Dr. Buana, do you have specific question?
Yes, a very interesting presentation because it's now 28 years that frontal fibrosing alopecia have been described by Cossard, and we see a lot of patients with this problem, and it's still many questions about the pathology and the treatments. For all, I would like to know if because I have seen in family 2 sisters with frontal fibrosing alopecia. So could you explain to us the eventual transmission? It's autosomal dominant or not? And about the treatment, I will wait the question of the audience because before asking the question about the treatment.
Thank you, Pierre. So you're asking whether it could be autosomal dominant FFA. Is that correct? Or of all the cases of FFA I've personally seen, there's only a minority are familial. And I think, while there have been descriptions of familial cases in the literature, I think they represent a minority. Of the ones that I've seen and of the ones that have been described in the literature, it would seem like if it were a familial disease, it would be autosomal dominant. However, I think it's more difficult than that. I think it's perhaps there may be other factors, but of all the cases that we see at the moment, only a minority are familial.
Okay. So I have just selected, thank you for your answer. I have just selected a question from Dr. Perez Meza from Mexico, and he's congratulating you on your presentation. And concerning LLP and FFA, he's asking, which is your advice for medical and surgical treatment?
So I think this is a very important question. Most dermatologists with an interest in hair agree that the disease has to have been stable for at least 1, but preferably 2 years before contemplating a hair transplant. Obviously, the difficulty with LPP, even FFA, which can affect the occipital scalp, is that they both potentially limit the availability of the donor hair. Now, even though clinically the disease might have been stable for a year or 2, may not guarantee the results. There's, I think, a study by Sergio and Spanish colleagues, which looking at patients who'd had hair transplants with FFA, who'd had hair transplants, and although after 1 year the patients had fantastic results, very few of them maintained their hair density at 5 years. So I think that if you're contemplating a hair transplant in those conditions, it is important to have that discussion with patients. Now, I perform hair transplants myself, and I often do a test area. I'm not sure what Sergio does, for instance, or here. I often do a test area before, even if clinically the conditions appear stable, before going on to perform a larger procedure. However, I do have the discussion that while their hair might look great at 1 year, that might not be the case at 5 years.
So Pierre and Sergio, what do you want to add on this?
Well, as I've said at the beginning, it's very difficult with this disease, but in my protocol, when the evolution is stable, non-inflammatory, I do a test and I wait 9 months before doing hair transplants. Anyway, we have to keep in mind to completely change our concept of hair transplant for frontal fibrosing alopecia, because we have to explain to the patient that they may have hair loss 2, 3, 4 years later, and some patient that I have transplanted many years ago, they said to me, do another transplant. I don't care because I have been with hair during for some years. So the patient is sufficiently concerned to be to know your explanation and to decide if you do a transplant or not.
So I understand right that you wait on your side 9 months that the disease is stabilized before the transplant, right?
That's right.
Okay, so between 1 to 2 years for Dr. Ball. Sergio, do you want to add something?
Yes, well, I think that it's vital to discuss with the patient the expectations of survival of the grafts in the long term. And if the patient accepts it, we can improve their quality of life with this procedure. I usually explain to them that the grafts will survive about between 3 to 5 years, and then another surgery can be considered. And in my hands, this surgery in stabilized patients, I go straight to the complete surgery. I don't perform a test because the patient wants to improve earlier. In my hands, it improves the quality of life, and it produces a high degree of satisfaction in our patients.
Okay. I have a question for you, Dr. Boru, is how do you explain the rise of FFA over the last decades?
I think there is still a big question mark over this. One theory is the use of one school of thought, the use of sunscreens and leave-on products, and recent studies have shown a higher concentration of nanoparticles, especially titanium nanoparticles, in the hair follicle of patients with FFA. However, there are some people who do not buy that theory, with arguments such as we see FFA in black women, for instance, do not use sunscreens. However, we know that a lot of makeup, a lot of other products contain an SPF. The authors who performed the genome-wide association study felt that it could. I mean, it seems evident that FFA has something to do with hormones, given that we see predominantly in women, especially postmenopausal women, given that dutasteride works. So they postulated a role for the oral contraceptive. So I don't think we have a clear answer yet. So these two things are potential suspects, but I don't think we're there yet in terms of what has caused this explosion in cases of FFA. FFA has gone from being something that dermatologists never saw to the most common scarring alopecia.
Okay. If you have one other last question, if you have a single advice to give to our audience
Dominic, I
yes,
have a comment.
Please.
Important comment, because in my opinion, because I have done biopsy of transplant on frontal fibrosing alopecia, and the process and the cell and the fibrosis around the follicle was seen on the hair transplanted. But what is important is that there are now male frontal fibrosing alopecia, and I think that we can explain the failure of some hair transplant because we have not done diagnosis initially of frontal fibrosing alopecia for male, and we thought exclusively to do a transplant for androgenetic alopecia. So I think we have to look very wisely the frontal area of a male patient before doing hair transplant.
Okay, I think this is a very important comment. Thank you so much, Dr. Buena. Okay, I think this is time to wrap up. Thank you so much to our faculty and to you, Dr. Buena, for moderating this and providing your comment.
Thank you.
Thank you. It's time. So just to finish, I like to remind the next webinar. This is in a week time on May the 18th, and we're talking a very interesting subject about the Gen Z, how to treat younger patients in the domain of aesthetic procedures. And this webinar is brought to you with the sponsorship of Vivacy. And then also for sure, we are waiting, we are thrilled to receive you in a couple of weeks in Paris for IMCAS World Congress 2022 from June 3rd to June 5th. Please join us if you can travel to Paris. It's going to be fantastic. We are going to be again face to face at least. And last and not least, this is also a month and a half after IMCAS will be in the America, in Cartagena, Colombia, between July 23rd and July 21st to July 23rd. For the audience being more in the south part of America, will be there and will be again happy to meet face to face in Cartagena. That's time. Thank you very much for joining, to all our audience, and thank you for the panel of speaker faculty, Dr. Buana, Dr. Valo, Dr. Roul, and Dr. Sadiq. Thank you so much.